Okay. Dear colleagues, dear friends, after the very nice day yesterday, I would like to begin with the first presentation from our colleague from Koblenz, Dr. Gerlach. Dr. Gerlach will speak about reconstruction of MCP joint with autologous rib graft after septic destruction of metacarpal head. It is seldom that during WAIOT congresses we have hand infection, but hand infection is one of the most important and very often problem in the orthopedic and trauma surgery and plastic surgery too. We have every day this problem in our hospital. Osteomyelitis of tibia is seldom our hand infection, very, very often. And I think it's important to speak about this problem too during the WAIOT Congress. Thank you very much. Please, Dr. Gerlach. Das ist, glaube ich, aufgerufen, Frau Gerlach. Ja?
Well, thank you very much. Good morning. Thank you for the introducing words from you. Yes, I have brought to you a case from our clinic. It's a case report concerning MCP joint reconstruction, taking a rib graft from our rib cage. And I will be leading you through the steps of reconstruction, but also I will be discussing the current available reconstruction methods of MCP joint destruction. Before I begin my presentation, I would like to tell you where I am from. I'm a fourth-year resident working at the Department for Trauma Surgery in orthopaedics, hand and reconstruction and plastic surgery, so everything is in one clinic, in our clinic, which is very nice. And I work at the German Military Central Hospital in Germany, which is about a 3-hour drive down the Rhine River. And where the Rhine River and the Moselle meet each other, there's the German Central Military Hospital. We have 5 military hospitals in total in Germany, and in Koblenz, it's the biggest one. We have over 500 beds and 2,500 employees. But we are not only responsible for the healthcare of our soldiers, we are also integrated in the healthcare provision for the civilian population, which is very important. So coming back to my presentation, as I said, I will be discussing the MCP joint reconstruction method, and there are no conflicts of interest. The initial situation. A 30-year-old young man was admitted to our ER after a work-related accident. He was working with a chainsaw and he unfortunately hurt his left dorsal hand. On the right side you see the X-ray, and as you can see, you see a total destruction of the MCP head of the second index finger. During clinical examination, we also saw that he wasn't able to move his index finger, so to extend his index finger. So there was a separation of the extender tendon. So the challenge with MCP joint destruction or injuries, or especially in the hand surgery, there's no standardization. There are plenty of case reports because there are more common injuries in the more distal phalangeal joints, the dip and the pip. And there was also septic contamination due to the chainsaw injury, as there was a lot of debris in that hand and in that wound. And there's a high risk of joint stiffness, especially in the hand, where every day is, every immobilized day for the hand is a problem. So what we did on that day was we initiated damage control surgery. After careful wound lavage already in the ER, we brought him to the OR on that day as soon as possible. And there was no possibility of refixation of that metacarpal head as it was completely destroyed. So after careful debridement and lavage, we chose to implant a cement spacer, which in this case contained gentamicin. Also, the extender tendon was primarily reconstructed in Kirchmeier-Kessler technique. So after that, infection control. The patient stayed in hospital for 3 days after that and got treated with IV antibiotic treatment. In this case, it was a calculated antibiotic treatment with cefuroxime and metronidazole. And the patient was immediately educated to refrain from smoking, as he was a heavy smoker. And the hand was immobilized in an intrinsic hand splint immediately for also infection control. After 6 weeks, we followed up on him regularly in our outpatient clinic. And after 6 weeks, you can see on the right-hand side of this picture, that was the intraoperative finding. You see the cement spacer. There was no sign of clinical infection, fortunately. So talking about operative reconstruction, those 6 weeks, we had to make up our minds what we do about this patient. And you have to take patient-related factors into account. Of course, age is a key role, the occupation, how long has the patient to be, has to work, what is his strong hand, and of course you have to take into account the comorbidities concerning diabetes, smoking, and of course, in hand surgery, always a very important point, compliance in post-operative treatment. And of course, surgical expertise. There are lots of case reports, as I said, and the current operative reconstruction methods, I will be leading you through a few of them. There's arthrodesis, which is always a backfill option in any case of infection control or bone destruction. In this case, not really suitable for that young man's age. There's prosthesis implantation. Currently on the market, we have the MCP Curryflex implant for MCP joint destruction, but also not quite suitable in this case. We're talking about the interesting thing, transplantation methods. You have to distinguish between vascularized and non-vascularized bone grafts. For the vascularized bone grafts, there's the pedicled bone graft, for example, taken from the distal radius, which is more used in distal radius or carpal destruction, not quite suitable for MCP reconstruction, as the distance that has to be covered is too far. There's the free bone graft, for example, taken from the medial femoral condyle, which goes along with a lot of damage, floor damage, and also a lot of pain. A little bit more easy accessible is the free crista iliaca graft, but as we heard from our patients yesterday, it's quite painful. Talking about non-vascularized bone grafts, we have to distinguish between the different characters of osteoinductive or osteoconductive features. We have the cancellous, corticocancellous grafts, which are characterized by their osteoinductive features, but they lack immediate bone stability. There's the hemihematum arthroplasty, for example, but not quite suitable for MCP joint reconstruction. And lastly, we have the cortical autograft, which we chose to do. So what are the advantages of a coastal osteochondral transplantation? There's a simple surgical access with low donor site morbidity. The patient is easily laid on his left or right side during operation, and we have an easy access to the rib cage. We generally have good graft quality. There's no polyneuropathia or peripheral artery disease in the ribcage area. There's a low risk of osteoarthritis, as the preservation of the chondral joint surface in this case is quite nice for joint transplantation and reconstruction. And we have an immediate bone stability due to the osteoconductive properties, and it allows us to immediately fixate the bone, which is best for post-operative rehabilitation. And to, taking the Genesis story, Adam and Eve, we have named this our Adam's operation. So taking you through the transplantation here, we see the 8th rib of the patient in this particular operation. You see the transition between the cartilage and the bone. On the second, you see after we've harvested this bone graft. Here on the right side, you see the bone wax, which we used to model the exact defect size that we needed. And on the left side, you see the graft itself from both sides. So here you see the hand. You see the picture after we removed the cement spacer and after we used the bone graft and fixated with a met aptus plate. And this was the post-operative picture. As you can see, you see the screws and you see there's a blank, but of course that's the cartilage. That's not X-ray tight, I guess. So concerning rehabilitation, we immobilized the hand again for 6 weeks in an intrinsic plus hand splint, but the patient was allowed to move with an occupational therapist after week 3. You see the picture here 6 weeks after the transplantation, and you see that it's the bone has healed. And here I have taken pictures from the patient who was about 8 weeks after transplantation, and he was able to move. Of course, there's still lots of movement that has to follow up. But in conclusion, reconstruction of bony defects of the MCP joint remain a challenge. There are many advantages associated with coastal graft harvesting, as I just said. You have to take into account the patient, and it's always an individual treatment decision-making. Of course, you have to have septic control, even in this case, after damage control surgery, so no primarily reconstruction. You have to have usually a high compliance for the treatment outcome, and it's important to talk to the patient. But lastly, long-term results have to be evaluated. So this was my presentation. Are there any questions?
This is a very interesting, Carlo. I think for the future of WAIOT, we need to speak about the problems of the hand. And Dr. Gerloff, thank you very much. I'm a hand surgeon too, and the very interesting for me was is a good idea for reconstruction. And if you have, don't have any success, you have later to have a silicone spacer. And you had better fundament after this, yeah. But it's a very good idea. Thank you very much. Yeah. The next speaker is Dr. Topçuoğlu from Klinikum Dortmund, and she will speak about burn and blast injuries. Very interesting, seldom presentations within the WAIOT. I'm very happy about this presentation. Please.
Thank you, Dr. Zetzfeld, for the invitation, and it's a great honor to be here and speak before so much experts. And I try to start. Yeah, ist hier offen. Ja. So. Started. Yes. Und dann haben wir noch den Pointer. Ach, die ist, ja, da ist. Ja, okay. I refer about burn injuries. At first, I won't start to tell about me and my clinic. We are a trauma department with a burn center. Our burn center is included to the trauma center, so we are orthopedic trauma surgeons and also treated patients with burns. And we are also intensive care medicines, have a specialty for, and have a station with 5 beds for burn intensive care patients. Burn intensive care are today more interesting because of the wars and of the injuries. And when you show in Germany, we have only such 120 burn care beds. And in the Ukraine, there have today 2 centers only in Kiev and Lviv. And we stay in contact with there. So we have regularly patients now from Ukraine, often soldiers from Ukraine, and I won't tell about this. So the data. We have since 2022 in Germany approximately 1,700 people with serious injuries and severe illnesses. We don't know about the correct number of serious injuries or severe illness. They are completed with 1,700. They come to us with a system called Kleeblatt. They organize the transport for these patients, and the ratio of civilians or soldiers are also unknown. The most patients we get are soldiers, and we in Dortmund get in the burn center with burns and also injuries and fractures are soldiers until now. The Ministry of Health in Ukraine, they said they have sent 60% of their injured patients to Germany, and also very much are retreated in Germany. The number unknown of surviving or deceased patients, we don't know. And in Dortmund, we have until now 18 soldiers with severe burns and following explosions. So they have also fractures. And it's interesting when I said 12 of them are deceased. And I want to tell today, why is this so? Why is burn injuries are so highly, so risky, and the survival is very bad? Because of the pathophysiological cascade of severe burns, you show, I sent on the right side, show you the EPSI score. The EPSI score says us how is the probability to survive deeply burned injuries. When you show or see when you are like 40 years, you have a point of 2 points, and you have, look on the side, severe burn, surface area are 60%, you get 6 points. And when you have a deeply and also inhalation injury, they get more points. So you have severe points about 10 to 11. You have a prediction probability rate of survival only 20%. This is the reason why so many patients are deceased. It's not only the problem of the skin, it's a systematic inflammatory response of the burn. They get a cytokine storm, oxidative stress, free radicals, and a loss of barrier integrity. The patients get a capillary leak, they have a hypovolemia. It's very high in the first 24 or 48 hours. And also they get organ hypoperfusion, heart, kidney, liver, gut, lung. It's a multi-organ failure at the end. So other patients who we get from Ukraine are burns, they have a trauma, and most of them, they have an infection. They have deep and extensive burns. Probably they had an inhalation injury, open fractures, impaired immune system. And with this impaired immune system, they also have contact with multi-resistant bacteria. When we get there to Germany, they have challenging transport conditions. They must transport, not like a medical transport. They are also with only laster. I don't know what's that. Trucks, and only they come to us with a desolate delayed. They have a delayed initial care for burn patients. They have the fluid loss, so we have the patients after 3 or 4 days. So we left the risky, the very important hours at the first time. Severe burn trauma. Also, we have the burn, inhalation injury, and the fractures. When I say the patient have 60% of the body surface area and their weight is 80 kilogram, they need also 20 liters of fluid in the first 24 hours. Our 18 Ukrainian soldiers have wide spectrum of organisms, multi-drug resistance. Also, they have Acinetobacter, Klebsiella, Pseudomonas, Enterococcus. They have 4-MRGN, MRSA, FARA-A, ESBL. 100% of these 18 soldiers are in bacteremia. They come to us in a septic shock. 18 of them, we 12 have 3 multi-drug resistant bacteria. 6 of them have multi-resistant bacteria. And 18 blood cultures have Acinetobacter baumannii, Pseudomonas, or MSA. Tracheal secretions are also the typical baumannii, Pseudomonas, Klebsiella, and they all 4-MRGN. The wound also colonized, but we don't treat the wounds local. We treat it local, not with the antibiotics, but the problem is the blood cultures. And how deep are their defects? 11 patients have over 50% total surface area. 7 patients are also 6 to 18. 14 patients have inhalation trauma, inhalation injury. 8 patients also with fractures and shrapnels. The difficulty in the therapy is that we have patients, we get them in the highly septic shock. They need volume, they need also antibiotics. The fractures have to stabilize with the external fixators. The internal fixation are not allowed in this situation. The inhalation injury needs a specific ventilation, and the organ failure needs support and replacement. The organ failure are also for a volume deficit and also of the antibiotics. And the burn injury or the burn tissue needs necrosectomy and the coverage. And this is also a trauma from the surgeon. So the killer of these patients are the multi-resistant bacteria, and 100% of them have a bacteremia. We need to take reserve antibiotics, target antibiotics. We are almost too late. They come to us on the 3rd or 4th days in the septic shock. And because of this, the patients have the multi-organ failure. We are also too late. Because of this, we have a collaboration with the Mechnikov Hospital. They come to visit us on May 21 to our burn center, and we want to make a new burn center day support in Mechnikov Hospital, and we hope that we get a better outcome for these patients. Thank you.
Thank you. Dr. Türklüt, fantastic presentation. There is a very interesting aspect in our field that you have trauma, you have infection after trauma, trauma after infection, but with burn together. And in addition, that is another number. Yes. Thank you very much. Impressive. The next presentation, dear friends, belongs to Shokat Ghazal. Dr. Shokat, please. We'll speak about Elizarov orthoplastic solution in post-traumatic infection. To the Shokat.
Okay, can you start?
This is open. I think it's open. Here you can see. You can close it. VGler haben wir gesehen. Dann muss eine von den drei sein. Yes, Dr. Shokat. Yes, thank you.
Hello. Thanks again, Dr. Tizvel. This is my second talk. Actually, this is talk of my professor, Dr. Fadel, and you know the reason that he didn't come in this Congress. I will talk about Elizarov orthoplastic solution in post-traumatic infection. Actually, the talk of yesterday of Dr. Schott is very conclusive, but I will take one solution from his solutions is infection, post-traumatic. Osteomyelitis is characterized by progressive inflammatory destruction. Diagnosis require assessment of radiographs, MRI, biopsy, and culture. Diagnosis require assessment. Treatment after a combination of antibiotic according to culture, surgical debridement, soft tissue defect combined with necrosed, exposed bone is a serious, challenging problem. Long-standing osteomyelitis with soft tissue defect must be attacked surgically. Aggressive surgical debridement is the mandatory till healthy bone and soft tissue reached. Many techniques described to reconstruct bone and soft tissue defect, and our colleagues yesterday talked much more about this reconstruction. For bone reconstruction, muscular technique is the most common reconstruction, but vascularized, non-vascularized fibular graft used. Bone transport is our main standard. For soft tissue defect, all these techniques require plastic surgery combined with orthopedic surgery. As we saw yesterday, the combination of plastic surgery with orthopedic surgery in the last talk. And this is a good option for orthopedic surgery to have plastic surgeon serving about decreasing the time of healing of infected bone. So, aim of our presentation, in our case example, we reconstruct both bone and soft tissue without need of plastic surgery, or if you don't have one, you can reconstruct soft tissue also by our technique. Our case, as we see, is bullet trauma, female patient, 27 years old, fracture both surgical humerus, open fracture of both leg. Gastillus 3, both surgical humerus fixed by phallus. Interlocking nail and the skin graft was done for the left leg, and this is the shape of the right leg that we will talk about it. This is the right leg. It's from other country. It's a Sudanese patient. Come to us after multiple debridement, external fixator, skin graft. And this is a photo, clinical photo that she came to us. What do you think about this bone and soft tissue, osteomyelitic bone, exposed necrotic bone, and soft tissue loss? Unfortunately, she went to plastic surgery and he did split thickness skin graft on this dead bone. Sure, it will fail. In our technique, we will. She was exhausted financially when she come to us, and there is no insurance in our country for the foreigners. So we are thinking about we will reconstruct this gap and soft tissue loss by one technique is by bone transport and soft tissue transport at the same time. Actually, the left tibia is non-united. The left tibia, which is fixed by interlocking, non-united also. But I neglected this leg for time to reconstruct the right leg, which is the big problem. She told to be amputated, but she refused, as she's a young female, and this is vital for her. Problem analysis post-debridement. Post-debridement, the dead bone, there's a long bone defect, large soft tissue defect. We clean the infection and dead bone till we reach healthy bone, which we could know intraoperative by a paprika sign, as all we know. Anesthesia, debridement, as we see. Direct approach on the anterior approach, on the tibia, till debridement was done and the removal of the whole dead bone, till the paprika sign appeared. This is the sign of the vital or live bone. As you see, the soft tissue inside is actually good, vascularized, not so bad. So we did the corticotomy proximal at the same time. I didn't see active infection inside in spite of chronic osteomyelitis. And we did corticotomy proximal and planned intraoperative to do bone transport, and closed by primary suture for just approximation and closing the skin, not tight. The gap is 12 centimeter. Yes, I'm actually doing the Lazarov hybrid technique, not all wire technique or chance technique, wire and chance technique. As the apparatus will stand with the patient long time. If wire technique, the wire after 2 or 3 months it will be loose. So I couldn't depend all the time on the wire only. And I use a hybrid technique, Italian technique, as we all know. Soft tissue. What about soft tissue? In our technique, we cover the bone proximal, which we transport. We cover them by soft tissue, the bone shorter than the healthy soft tissue. This will transport the bone and soft tissue with it. Lazarov technique treatment method using gradual bone distraction with or without soft tissue release lead to not only bone lengthening but also soft tissue. Result as this we see. Distraction the bone at docking site. We must open at the docking site and what a graft. Very, very good regenerate as we see. Healthy bone. She is a female, non-smoker, healthy. This is the shape of the bone of the regenerate of new bone after removal of Lazarov. It took with us 10 months, but she's happy for this. And she's walking with cast. When she's walked with cast for the first time, when she came to my clinic, she was crying. That for fear that I will tell her for amputation. But when she's walking, also cried from happiness. She's walk again. And this is a shape. There is some problem with the shape of the skin. And she told me that's okay. I will take a cosmetics and plastic surgery. But the bone stock is very good and well. And she sent me this video from her country, Sudan, after she left our country, Egypt. She walking in her garden between his children. And after 1 year, she get pregnant again and delivered the other baby. Discussion, the management of bone and soft tissue defect in leg bone set plan. The plan showed suits each procedure. Compensate soft tissue gap with a flap or distraction hysteresis. Take-home message, Elizarov technique was found successful method for reconstruction of large gap, bone and soft tissue, consequently, without need for many operations that might increasing morbidity to the patient and also financially. Early patient normal daily activity and work. Thank you.
Thank you very much, Dr. Shokat. I think just a little inner rotation is better than without leg. Thank you. Professor Osman, you have the next speaker about amputation with reconstruction in the mangled lower limb here. Yeah. Stage is yours. You have, I think, here, Professor Osman, here. Yeah, here. He's one of the. Yeah. Ah, okay. Yes, and please.
Bismillah ar-Rahman ar-Rahim. Thanks for Dr. Tesfal for invite me. Very nice conference, and also thanks for Oli. He started the journey from the Düsseldorf airport. Thanks also for the Dr. Fadel. Dr. Fadel is the guide for orthopedic cleansing and reconstruction in Egypt, and also have an institute, International Institute of LRS, collect all surgeons all over the world having training in the LRS in Egypt, and also collect the paper and advise all doctors in Egypt to connect with WAIOT. My talk today is a problem of amputate or reconstruct the mangled limb. Yesterday, my colleague talked about the mangled limb, and also I continue for this series. My hospital in Damietta in Egypt, about 300 kilometers from Egypt on the Mediterranean Sea, and having intercoastal road, translate Port Said, Damietta, Alexandria, and As-Sahel. Also, this intercoastal road having a traffic accident every day, major accident. My hospital, Azhar University Hospital, 7 minutes from the road. We show a major accident every day and mangled limb, not classified in the box and in the AO and soft tissue. This is the cases in my AR. Sometime we pushed to amputate the limb. This is a female patient, 16 years old, train accident. The body coming and they lost the foot, both foot in the train, behind the train. And no choice, this is for amputation bilateral. When you need to save life and unable to save limb reconstruction, you save the life first. Amputation is a solution. American Academy take about 10 years in the reconstruction. Consume much dollars, consume much organ failure and exposure to anesthesia and drugs. But the amputation is a solution sometimes to save the life. Background, mangled limb injuries involve severe damage to the bone, vessels, nerves, and soft tissue. Decision-making remain controversial between salvage or early amputation. Goal, to optimize the survival, if possible, and function, if possible, and the quality of life. Aim of the study to compare outcome of limb amputation versus reconstruction, evaluate the functional recovery, complication, rehabilitation, and patient satisfaction. Total sample about 30 patients, and 1 patient from the 2 group, 1 amputate the limb and reconstruct the upper limb to save the life. Method, prospective observational study from 2020 up to 2026. Azhar University, Dimyata, Egypt. 15 patients treated with primary amputation to save the life. 15 patients treated with limb reconstruction. 1 patient, case number 4, had 1 limb early amputation and the other is reconstructed. Assessment with MES score, infection rate, and functional outcome. Amputation group, 15 cases. Indication, irreversible ischemia, extensive contamination, complete nerve disruption. Average hospital stay shorter than the reconstruction group. Early rehabilitation and prosthetic fitting, lower rate of repeated surgery. Like this patient. Reconstruction group, 15 cases, procedure, including vascular repair, external fixation, flap coverage, and bone grafting, higher limb preservation rate, multiple stage surgery frequently required, longer rehabilitation, and may need to amputation at the last. Amputation versus limb reconstruction. Amputation procedure is simple, but not a standard flap. Complication, infection, wound dehiscence, chronic painful limb, phantom limb. Limb reconstruction, risk of infection, wound dehiscence, flap necrosis, blood loss, DVT, long-term complication, periprosthetic fracture, non-union of graft-host junction, allograft problem, multiple future operation, 1/3 of the long-term survivor need amputation. Limb reconstructive surgery, functional outcome, psychological and cosmetic factor, Malwire in 2009. To salvage or to amputate, there are 2 cases. Most of mangled limb can be salvaged after trauma and with advances in skeletal fixation, limb reconstruction. Thus, the dilemma that reconstructive surgery facing is no longer how, but whether attempted salvage is the best treatment option for the patient and the final decision for the patient and family. The decision to salvage or amputate challenging for the managing team as they are facing to the several factors that require thoughtful consideration before embarking or other salvage surgery, long and winding path or irreversible, and the final decision may amputate the limb. There is several paper and journal about the amputation versus the reconstruction. This is Medicinal Journals 2020, multiple step for the function reconstruction of the mangled limb. What's the conclusion? Limb salvage versus amputation after soft tissue debridement and infection. What's the decision? Query. Maybe, maybe. In Curious, 2022, limb salvage versus amputation for mangled limb, factor decision-making outcome. Also, query, conclusion, limb salvage versus amputation is equivocal, amputate or not. Also, European Journal of Orthopaedic Surgery and Traumatology in 2020, the limb salvage versus amputation is equivocal. No decision to, for amputation or for reconstruction. This paper from Egyptian Journal of Surgery both financial and human resources, and the evidence regarding the benefit of limb salvage versus amputation is also equivocal. This is 2025. This is the key. Cash Johnson, this is a miss score at the 1990. This is the update up to the 2026. Mangled extremity severity score. Advice in 2026. All patients with significant trauma require through trauma assessment and resuscitation. Trauma victim require management of significant, first, craniocerebral, second is thoracic abdominal and pelvic injury prior to consideration of the limb salvage. And also, upper extremity are profoundly more important functionally than the lower limb. Okay? Upper extremity processes are much more primitive and less functional than the lower extremity processes. Conclusion, that guarding the soft tissue and skeletal injury, ischemia, presence of shock, and patient age, surrogate for the medical comorbidities seem to predict limb salvage success or failure at the score 7. But this is a Mangled score in 1990. Is a simple rating scale for the lower extremity trauma based on 4 significant criteria. Patient age is very important, limb ischemia, shock, and skeletal or soft tissue. Case presentation. I have in this case, female patient, 4 years old, road traffic accident, had open segmental fracture type 3C of left post ball leg. Reconstruction versus amputation. This is a grade 3C open fracture. Muscle distracted, anterior tibial artery occluded, common peroneal affected, and skin massively injured. According to the miss score, this is the 7. Was the decision is amputation. Who took the family? Refuse the amputation for her children. No, doctor, please keep the limb, whatever the shape of the limb. Try to reconstruct. Reconstruct simply by the Nancy nail. Then the 2-week follow-up. After 4 weeks, surgical debridement was done and the resulting exposed bone, plastic surgery recommended VAC application. This is 2 weeks after VAC. Reconstruct or amputate. Reconstruct, please, doctor. After 2 weeks after VAC, still the osteomyelitis of the bone. 4 weeks after VAC, remove part of the osteomyelitic bone still. 6 weeks after VAC, external fixation and remove the excision of the sequestrum and do bone skin grafting. External fixator and the grafting, dequinous foot infection, stiff ankle, drop foot. Did bone segment removed and the external fixation. Still the patient having the, to reconstruct whatever, this is my children. Okay, we'll do limb reconstruction by the Elizarov and include the foot to correct the equinus. Do segment transfers, this is a small segment. We can take the epiphysis also arthrodeostasis. This is a case happy to wait peer the first post-operative of the follow-up 14 days after latency, 3 months, segment transfer start, 6 months, and there's he woke. Segment transfer after remove the Elizarov after 2 years. 7-year follow-up. The decision for the family, not for the doctor. As a Mrs. score gave me 7 amputation, agree, amputation from my view, but from the family true after this result. Case number 2, male patient, 20 years old, road traffic accident, open supracondylar, intercondylar femur, segmental fracture, grade 3C, post-pole leg. We do reconstruction and the infection. And the infection in my hand, a pen track infection was a level of 110 per 100. 110 per 100. Infection so massive. Reach up to ring sequestrum around the wires, and this is a follow-up 4 months, 6 months, 16-year follow-up. And the MES score is 7. Male patient, 20 years old, road traffic accident, open and segmental type C3, post-pole leg with fracture pelvis, stapulum, and this is with vascular injury. Amputate the one limb and reconstruct the pelvis. And this is the prosthesis, and patient happy for amputation. And decision for the patient, not for the family. Patient tell me, whatever, operation every other day, amputate and do this prosthesis. This is a male patient, 18 years old, road traffic accident was open segmental grade 3C in the right femur. And the other is massive injury and vascular injury. We do early amputation to save a life on the left side and reconstruction of the right side. And also there is reconstruction every other day. We do debridement for infection, for non-union, for the problem of the long-term operation. This is a follow-up. Result of comparison. Amputation group, faster mobilization and lower cost. Reconstruction group is better psychological acceptance in selected patient. Complication is higher in the reconstruction group. Functional outcome depend on injury, severity, and timing. Discussion. MES score is useful, but not absolute. Multidisciplinary approach is essential. Patient age, occupation, comorbidities influence the decision. Early definitive treatment to improve the outcome. Not universal solution for the mangled limb is amputation. Amputation may provide faster recovery in severe injuries. Reconstruction appropriate in the careful selected patient. Shared decision making remain critical. Take home message. One of the most difficult problems in traumatology is open fracture of the post-pole leg with additional severe soft tissue damage. Tibia, because of its location, its structural anatomy, its spare of anterior coverage, soft tissue is particularly prone to the severe open fracture. Our treatment protocol emphasizes on the debridement, irrigation, antibiotic therapy, fracture stabilization, and appropriate wound closure. Wound closure and soft tissue management took our priority in open fracture over the bone healing. All the study done so far have emphasized the soft tissue coverage and subsequently early bone healing. Please, don't amputate if you have a chance. Teamwork is a very important in orthopedic, including orthopedic, plastic surgery. It's a very important in managing of open fractures. Initial debridement is the improvement is important in reducing the infection, and learn the genuine how to good debridement for the early wound and other complications associated with soft tissue coverage and skeletal stabilization. Early soft tissue coverage in acute phase should be priority whenever possible. In crush injuries with extensive soft tissue devitalization, soft tissue coverage should be delayed to allow second look and serial debridement of the wound. Negative pressure therapy is very important. Early physiotherapy is very important from the first day. Finally, treatment of mangled limb or mangled extremity is very difficult. Life before limb saving or amputation. Limb salvage procedure lengthy, associated with significant morbidity, reoperation, consuming health and the body system, and the loss of function, painful limb, final amputation. Thank you. This slide, a patient dream to walking with a foot. Our target to provide patient with best treatment instead of the technically possible for the surgeon. Thank you.
Professor Osman, thank you very much for the impressive presentation. Dear colleagues, do you have any questions? After the discussion, we have a break, and after the break, we have a demonstration and simulation of Ilizarov fixator. Please, your question. Mm-hmm. I have a question, Professor Osman. I think MES is correct, but the fundamental decision-making after traumatic amputation is blood supply and the sensitivity of the foot or for the hand. Yes, I think these two parameters are the fundamental parameters for the decision. Is it so?
Mrs. Score is helpful, but not absolute.
Yes.
We show the cases, the family is refused. Whatever the Mrs. Score agree to amputate. I agree with the family to try and follow up 7 years is good limb working, okay?
Yes.
But the miss is not conclusive. But you're having a document, medical legal, for the amputation.
I think, thank you. I think in the near future, the artificial intelligence will enable to help us for this decision. I'm sure. You have the lot of parameters, and you have at the end of the parameters the result and the decision from AI, but I think the individual decision for each patient, for the parents, remains, yes, it's a question, yes.
I agree with you.
Yeah.
AI helped me, but AI is a machine, not having heart,
Yes.
not having family. Yes, you agree with me? Okay.
Yes. And we are not be able to give all of these parameters to the machine for the decision. That is very difficult. That is another part. Thank you very much, Professor Osman. Next question, please. Yeah.
Also for Professor Osman, were there cases where you were successful in reconstructing, but after the follow-up, after several years, where you would have said, okay, the better option would have been to amputate? So where the reconstruction was successful, but in the end you would say, okay, we should have sticked maybe to the score and amputate, or is that never the case? If you are successful?
It's a good question. I'm waiting for this question. Yeah, after complete reconstruction and patient walking with painful limb. Painful limb is a problem. Patient can cry every day, every hour from the limb, taking tramadol, taking analgesic every hour for the painful limb. And after 7 years, come to me, yes, please amputate this painful limb. This is one case. Another case after 10 year follow-up with good reconstruction. But every now and then, Dr. Testival yesterday, a patient coming here in the hospital, and there is a small sinus every 1.5 months, every 2 months, coming bus debridement and culture sensitivity, okay? Organ failure, you must do assess the patient liver function, kidney function, patient to go to the kidney failure. Remove my limb to keep my life. Okay.
Thank you very much. I have a question. Thank you very much, Professor Osman. On Dr. Topçuoglu. The question is, are there any difference in the antibiotic therapy or prophylaxis in trauma with burn? Gibt es einen Unterschied hier in antibiotischer Therapie, ob das jemand verletzt ist oder ist das verletzt und verbrannt? Das Vorgehen, ja.
No, we don't take a prophylaxis, only in therapy. When they're infected, that gets the therapy, but not a prophylaxis.
Yes. This is in burn injury is, I know the antibiotic prophylaxis is not so like other open fractures or the open injuries. That's
We
correct.
take it very late because when you take it very early, you get multi-resistant drugs very more earlier, and you have the difficulties of this.
Yes, okay, thank you very much. Yeah. Other questions, dear friends? Okay, I think we make a 10 minutes break, and after the break, we have demonstration for Lizarov. Thank you very much.
بيغطوا كل حاجه.
حد يصورنا اسم التليفون. اصور حضرتك اللي هو فيديو.
احنا دكاتره، احنا دكتور عثمان، احنا هذول هم من اورثوبيدكس. احنا بس انت لو حاب تشرح عنهم انه هذا الارش وهذا 5 والهايف والكومبليت، بس اللي حنشتغل فيهم بس
دول
معنا جهزتهم.
هتعملها بروكسيمال.
هي حطيتها انا على اساس انه بروكسيمال. هو المشكله انه حشرنا فيهم انه عاوز يوفر الجماعه، لانه هذاك
مفيش حاجه يوز ده عندك
عارف
الطب.
ما هو مفيش، ما هو اليوز راح تمام. فهو حيكون يعني انه الفريم انه هاي بروكسيمال تو ليفل فيكسيشن تمام. حنثبتهم 2 سكروز وواير، والديستال حيكون هيك. يعني هو الكونتراكت على اساس انه هيك تمام. لو بدك اي شيء كمان نفتح نحط.
لا مفيش شيء.
انا اتفقت مع تبع الشركه حيحاسبنا هو على هذول. تخيل.
يلا يحاسبك انت؟
لا حيحاسب المستشفى على الفاتوره، وهذاك حيحاسب الرئيس. ممنوع
يا راجل
والله
ليه؟
عشان هيك
فعلا؟
خلاص ما بنشرحش.
ايه ازاي
ده انت المفروض تكون تكتبه اصلا هو
ناخده معانا؟
شايف
خلاص
يعني هذول مش هيرجع وقال لي هاتهم.
حالات
مفيش حاجه قديمه غلط في العمليات.
مفيش. احنا نصور
لا صور عادية مش هي صور. ماشي. صور
einmal kurz mitkommen? Ich will einmal kurz das zeigen.
هو اللي دعاية الشركة نفسها يعني هو مش عايز دعاية. هو مش عايز دعاية.
مش فارق معايا الدكتور العالية دي. شايفنا؟ طب استنى هو يعمل.
شغال فيديو.
فوتو حتى.
شغال فيديو.
Wo mein Fixpunkt?
هيك وهيك وهيك. هيك.
Ja, machen wir einen.
الإشي.
الريفرس.
ماشي.
الريفرس لا تضغط عليها اثنين.
تضغط الاثنين.
مع اثنين.
Ja, wir gucken gerade, wie wir das am besten, weil ich kann die Kamera nicht für rechts, links, ich kann die nur rotieren lassen.
بس كلها ده
Das war super.
لا اسم ثاني.
لا ده اسمه نفي.
Also das
في دي بقى.
hier, das hier ist die Mitte.
يا اوكي.
Das ist die Mitte.
احنا يا دكتور الشرح
ماشي.
الدكتور حتشرح لي ما احنا حنركب. حيكون التركيب عشان الكاميرا او شيء حيعمل زوم. هو حنشوف هنا حنشتغل هيك يعني تمام. حنشتغل هيك ونركب الزوم هيك تمام.
طب امتى نبدا هيك؟
بس حكي
هسه؟
هو هيعمل دلوقتي. احنا نعمل فريم عادي بس وخلاص.
ايش؟
فريم عادي بس ترتيب له بس يعني.
تمام. بس احنا لو احتاجنا قلنا لو احتاجنا اي شيء حنعطي الدكتور وهو يتكلم.
مش مشكله. هو سامعين الساوند؟ في صوت؟
لسه
ماشي.
لسه مش
اعمل الحلاوه دي.
هي البيانات.
الحاجات تحس ان احنا بنشتغل مش في زباله زي بتاع كنت في ليبيا وعملنا ورك شوب. طلعوا لي صينيه عمري ما اشتغلت بيها في حياتي يعني.
انت عارف اسمه محمد عبد العال؟
نعم.
بتاع الازهر بتاع
ده تلميذي يعني.
هو مسافر دلوقتي.
ايوه ما هو لي 10 سنين مسافر.
اشتغلت معانا في البدايه اول ما خلص الام دي كده. كان في 2010. راح هو شاف السعوديه في المنطقه الشماليه، قال له رحت هناك جابوا لي علبه بتاع سبيس ليف وانا ما شفتهاش في حياتي، اول ما اشتغل هناك. قال لي اشتغلت الحاله ولا اشتغلت الحاله، تاني يوم لقيت الصحافه
استنى
الايه؟
هنبلش خلاص،
الصحافه بتتكلم.
هنبلش ان شاء الله. عزيز انا جايبك تساعدنا. لا تسكت، تسكت بعدين.
Can we start?
1 minute.
1 minute. 1 Minute.
في مايك ولا
هو المايك سمعنا، هو المايك سمعنا.
مايك سمع؟
Eine Minute. Nein, ich habe, ja, eine Minute haben wir bestimmt. Okay.
محتاج شيء
لا مش محتاج شيء.
خلاص.
حلو الدكتور.
طيب
انت هتروح فين؟
انا واقف جنبك.
يا الله
أنا واقف جنبك.
ده شرف.
شرف
الله
لي
حبيبي
انا.
حبيبي حبيبي.
شرف لي انا.
So. Minute brauchen die Jungs für die Vorbereitung drüben. Unsere last session. The colleagues are preparing. Are you ready? Fine. Okay. Dear friends, we begin with the last session. For first, we have a live demonstration and simulation of a fixator, Elisarov ring fixator, on Sauborn, and our colleagues from Egypt with my colleague Dr. Olvan try to demonstrate the principle of Elisarov ring fixator. I thank the college for this possibility. On approximately 20 to 30 minutes time we need for it. Mr. Frank, I think the college can begin.
3, 2, 1. Yeah. We start today the Elizarov for the post-pole leg assembly and the supine. This used for the fracture post-pole leg, open fracture, segmental fracture, or deformity or segment transfer. Must to know before this reconstruction of the Elizarov frame, the safe corridor, unsafe zone of corridor, and hazardous zone of corridor. The safe zone is the area which the bone is subtenuous, no important tendon, no important vessels. The hazardous zone, like important tendon, is the tendon Achilles here and the posterior part of the ankle. You take care to both K-wire or to both the chains screw. And hazardous unsafe zone is the posterior part of the tibia, which contains the comprehensive nerve, posterior tibial nerve, and posterior tibial vessel. Don't insert wire or chain screw. Having to construct, proximal construct from the articular surface, must to know the articular surface first to put a needle of the syringe under the C-arm to know the articular surface, to prevent to put the K-wire or chains in the articular surface, and also the ankle to put the needle of the syringe 10 centimeter in the ankle to know the articular surface above and below. Proximal construct, we do the 5/8 ring, 2 centimeter below the articular surface. Every construct or every ring or half ring or 5/8 ring to put 2 chains, 1 wire or 2 wires or 3 wires. We put more for follow up, sometime wire loosening, pen track infection to remove one and to leave the construct stable. 5/8 here, you see, and below is about 5 centimeters, the second level, we put a complete ring. Why to put a 5 or half ring here? To allow the flexion of the knee. Can put the construct complete 2 ring here and the comminuted with the tibial plateau or proximal tibial fracture. Can put both ring in the proximal. Okay, and the other construct, down construct, is above the ankle, about 2 ring, complete ring. One is 2 inches above the articular surface, and the above is 4 inches below. Why to elongate this construct? To give more stability. When you put a 2 ring here and 1 5/8 here, the torsional force is more for the short area. But when you put a long, this is no torsional force for this construct. Okay, we'll put the 2 chance screw. Okay. Yeah.
خلي محمود يتكلم.
Yeah.
اتكلم بالالماني محمود لو عايز.
Yeah. Yeah.
So 5 millimeter screw.
Yes, it's chance. The choice of the chance is about less than or pin less than 1/3 of the circumference of the proximal tibia in the safe corridor. We allow here 1 or 2 serration outside, not more than to avoid to injure the important structure or important vessel or important nerve. Okay? The construct combined from wires and okay.
خلاص احنا خلينا نشتغل على هنا. نشتغل على هنا.
We have types of change screw. Change screw, self-tapping, self-drilling, and pre-drilled. To drilling by the drill bit to 3.2. And this is the proximal construct. We put a 5/8. تعال هنا يا دكتور عبد العزيز تصور. Yes. Okay. This is a proximal construct. The bone is centered in the 5/8 ring or the complete ring center. Yes, to avoid the deviation of the construct medial or lateral or anterior or posterior to avoid tension on the soft tissue. Yes, this is a proximal construct. We got the distal construct. Yes.
5 2
Yes.
ولا الوقت يعني؟
لا لا مش عشان الوقت، عشان
خلاص عايزين نحط رباط ما بين الديس والبروكسيمال عشان ما نتعب نركب الشمس.
اوكي.
فين الرودز يا محمود؟ عم الرودز.
نحط بس البتاع ده نوصل. اوكي
عشان بس ما يبقاش
ماشي.
عشان
ما احنا في ليميتيشن بس. اوكي. When you put a rod, put nuts here and nuts here. And centralize the
طب خلينا بعيد شويه عن الرود اللي تحت ده. عايزين واحد كمان تحت يا دكتور محمود.
theoretically to put this rod in the axis of the bone to show the axis of the bone here.
واحد كمان هنا.
The other.
هاتوا اللاتر هنا. اللاتر هنا يا حود عشان نشتغل براحتك.
قدام واحد قدام واحد ورا.
واحد اهو بصوا
لا
اللاتر.
تختلفوا فتختلفوا. انت ما عندكش.
لا لا فوق شويه. تحت. ايوه ماشي.
Yeah. This is simply. Now you go to chance. The drilling was interrupted, not continuous drilling. Okay, interrupted to avoid the thermal necrosis of the wound. Yeah, one or two.
الاثنين
ماشي اوكي اوكي. عايزين ورقة، أي ورقة أي ورقة، منديل منديل منديل. Yeah. مش مشكلة. With the insertion of the wire, you have must goes with saline. Yes. We put in the anatomical. Interrupted with the goes with saline to avoid the thermal necrosis. Okay. Not to complete the wire by drilling, by hammering, to avoid the spining of the soft tissue around the proximal part. Okay? But in workshop, the bone, soft bone is very difficult. Let's see. There is a types of wires. This is the olive wire, allow to reduce the fragment of bone, to displace the bone. This is the olive wire. This is a bayonet. What is the bayonet wire? This is a normal wire. Bayonet wire, which have the bayonet wire, yes, for the laser. Yeah. We bought the. This is a pin holder. We close here from the side of the olive wire, and last and we do tensioning. This is a tensioner for the single wire on the half ring or 5/8 or single ring. We tension for the 90 Newton. For the complete ring, we tension for the 120 Newton. Okay? The assistant on the other side, we take by the both hand the proximal and distal ring. Okay? Yes. Yeah. Okay. We remove the tensioner. We cut and must to catch the distal part of the pin and to bend the wire in a smooth curve. Also here, in a smooth curve. Yeah. This is the frame assembly for the osteotomy, for the lengthening, for the deformity correction of the proximal tibia, 1.5 ring or 1 ring and the 5/8, and the distal block is 2 ring, and we put 2 chains and 2 wires, 2 chains and 2 wire. If you want to segment transfer, we put this ring distal about 1 inch from the ankle line of the joint, and put to dead ring. If you want to do segment transfer, do dead ring, because the long bar we put torsional forces is more. We put a dead ring to translate the load from the upper part to distal part.
Thank you.
Okay, thank you.
Thank you very much.
If you want to take a picture, it's okay.
You can say,
No.
Yeah.
in construct for the Elizabeth assembly, that's for the construct 2 block proximal and distal block.
Yeah.
For the proximal and distal. Yeah, for
Frank, können die Kollegen mich hören da
full
drüben?
level of fixation.
Ja.
Full level of fixation.
Ne. Sag mal, wir haben es gesehen, wir bedanken uns, Sie können reinkommen.
Full level of fixation.
So.
So. Die Fragen, questions from the room in this camera.
Frank, sag mal zu Olli, die Diskussion können wir gleich hier drin machen. Ja, komm rein einfach nochmal. Okay. I think we can make an applause if the colleagues are here. Yeah.
Yeah, okay. Welcome.
Thank you very much, and the colleagues. We will see the colleagues in this room again. Then we begin the last session with the first presentation from colleague Siberat. From Siberat, development of a bone cell interaction assay for the preclinical evaluation of bone integration of new materials in immunocompromised bone metabolism conditions. Siberat, thank you.
Yeah. Thank you very much. So maybe a bit more of an exotic talk now. It will be more basic research rather than surgery techniques. First of all, I would like to talk about the development of new approach methodologies, and then we'll go on and talk a bit about our project, which deals with the development of this kind of bone cell assay. I'm Alex, and I'm the postdoc at the Department of Experimental Surgery at the University Hospital Knappschaft Krankenhaus Bochum. And our research department is located at the Center for Clinical Research at the Rio University. And our overall mission, or Jochen and my main goal, is to advance human in vitro models that can bridge research and clinical application. So first of all, a little introduction. So what are new approach methodologies, short NAMs? They are innovative non-animal technologies and methods that we use to evaluate the safety and efficacy of chemicals, drugs, or new biomaterials or biomedical products. They aim to transform biomedical and toxicology research by better predicting human outcomes or responses of humans to materials or new drugs, while replacing the need for animal models. So why is it important to develop these NAMs? Because animal models in preclinical research come with many disadvantages. Here are 4 that I want to point out. First of all, mainly the low predictive character of animal models. So many drugs or materials that work in animals fail in the end in the human body. They suffer in general for low throughput, so we cannot test a big library of materials or drugs in these animals. Usually the development in animal models comes with high costs. You need personnel to take care of the animals, you have costs for food and so on. And lastly, it's against the 3Rs initiative of the EU and FDA, so many regulatory bodies urge researchers to reduce, refine, or replace animal models in their research. So this leads to the conclusion that there is a big need for human relevant cell assays and organ-on-a-chip systems, and their development is critical because animal testing often fails to accurately predict human biology. The increasing relevance of these NAMs is more and more also represented by regulators and funders. They are demanding more predictive and human relevant models in our applications for funding, and always with the goal that our research in the end should translate into real patient impact. As these models give a clearer disease understanding and better mechanistic insights in human biology, and then can also in the end act as an accelerator of new biomaterial or drug development if they are suited. So that is the overall motivation to develop these NAMs, and an example for such a NAM is our project Cluster Integration, which aims to develop a cell-based in vitro platform for testing implant surface topographies or novel materials. We do this project together with the Fraunhofer Institute for Laser Technique in Aachen, so our lab from the Knappschaft Kliniken Bochum, and the company Hydromil, which structures implant surfaces with a water jet, and the company GFBS, which is yeah, an expert in the regulatory aspects. So the overall aim of our project is to is the development of a development and validation of a preclinical predictive in vitro bone cell assay that is based on human cells for testing biomaterials and their applications in human long bones. If we are successful, the model should lead to faster testing and the faster testing and development of implant modifications and novel materials and significant reduction in animal testing. The objectives within this project is that we want to assess osseointegration potential of topographies and materials in vitro, and also evaluate whether the hydrojet process, which is led by the company Hydromil, is a novel or suited process or a cold tool in comparison to laser to macro and microstructure implant surfaces to boost osteointegration in the end. Now I want to give you just a short overview what our approach is in developing this model. Here you see a quick outline. So we start with our structured biomaterial. If you go from left to right, we start with our structured biomaterial at the bottom of a cell culture well. We incubate this biomaterial then with human serum proteins to simulate blood contact. Then we seed human mesenchymal stem cells from the bone marrow on top of this material, which are the precursors for the bone-forming cells, the osteoblasts. We culture these then for 2 weeks under osteogenic condition. And then we put a transwell, which we coat with an osteomimetic matrix on top of the biomaterial and cell sheet. Within this transwell, we also have the precursor cells of osteoclasts, the mononuclear cells, and then we culture this construct for another 2 weeks together so that the HMSCs can differentiate into bone-forming osteoblasts, and the mononuclear cells can differentiate in bone-resorbing osteoclasts. And within this culture system, we can then simultaneously assess the mineralization and resorption activity of the cells. And you can see that on the right. On the bottom right, you see typical mineralization staining, which is alizarin in red. So here we have the surface of the biomaterial that we stain for new minerals. So the more red we see, the more minerals are formed. On the top right, the green image, you see an image of the transfer with the osteomimetic coating. The osteomimetic coating is shown in green, and the black dots are the sites where the osteoclasts started to resorb the coating, so the bone matrix. And with these two, so that we can measure these two activities then. So on the top, we can just use image analysis to measure the black area, and then we have a quantification of resorption. And in the bottom, we can just elute the dye and then measure how much dye we eluted, and then we have a measure for mineralization. So with that, we can then see what is the balance. Are we more towards formation or more towards resorption? Here's an example image then, how that looks like. So on the left, you see a hydrojet structured zirconium dioxide disc, which was on the bottom of the well, and on the right, you see a transwell where we had the resorption according to the topography of the implant, the biomaterial at the bottom. So that is the state where we are now. So we set up the model. We can measure both activities simultaneously, and now we are going to test how different macro and microstructures on these discs can assess both cell activities. And with that, you can imagine we can do that in high throughput. We can test many different topographies in a quick time. Once we identified promising topographies, we will then start to further evaluate the mechanistic insights. So what drives more mineralization, for example, or resorption on those candidate material structures. So here we will then assess molecular markers with qPCR or the rank LOPG ratio, the release of these substances into the culture medium for osteoclasts and osteoblasts. So that is the state of the 3D model, and then just quickly, another part of the project is to evaluate whether this hydrojet process could be a new tool to structure implant materials. A shortcoming or a difficulty of that process is that hydrojet also uses abrasive particles during the structuring of the implant surface. So we want to assess whether if we have particles left over on the surface, because we cannot wash out every particle. Some are also integrated into the material, like loosely, and then can get freed up after a certain time. So we want to see to what extent can these particles, if they are on the surface and then are in contact with the bone cells, influence their viability or differentiation, to assess whether the process could be used for implant structuring. Here, just quickly, I don't want to bore you with graphs. In principle, what we could see here we measured the viability of bone marrow mesenchymal stem cells in contact with different particles. And what we could see in conclusion is that the cells did not really bother if the particles were present during culture or not. On the left, A and B, you see two different types of viability assays. On the left is always the control without particles, and the others always show different types of particles that we assessed that could be used during the hydrojet process. On the right, you see live dead images, so living cells show up in green, and we could see that we had a comparable amount of cells in each condition. So here we concluded more or less the bone-forming precursor cells did not bother too much. We also could see that in the electron microscope analysis that we did afterwards. We could see that the particles stick to the cells or to the plasma membrane. We are not sure what the mechanism is so far, but they did not really engulf or interact with these particles. They just stick to the cells, which, fitted our quantification of viability data, that there was no big impact. However, when we looked at the bone resorbing cells, the osteoclasts, in direct contact with these particles, we could see that there is definitely an impact. On the left, you see the no particle control. These large pink cells, multinucleated cells, are the osteoclasts that you see there. That form quite nicely in vitro through fusion of mononuclear cells. And on the right, you see the particle control. And as you quite strikingly see that we almost have no cells there and definitely no osteoclast differentiation. So the particles on the bone resorbing side definitely made an impact. We also there had a look on under the SEM what happens. And in contrast to the HMSCs, we could here see that the cells definitely interacted with the particles. They started to engulf them, as you can see on the red dots here and there. So rather than just like, let's say shoving them around like the HMSCs, the osteoclast precursor cells were more interested in these particles and impaired their differentiation to osteoclasts in the end. So here we are now evaluating what concentration of particles would impair, or what threshold of particle concentration can we give to the cells without impairing osteoclast differentiation. And once we find that concentration, we then will evaluate, okay, does that fit, or does that make a problem for the process because we have, I don't know, so a certain amount of concentration always sticking to the implant surface. And if that would be the case, then the hydrojet process would be probably unsuited for structuring these implants. But that is something that we will find out in the future now. Yeah, to sum my talk up, so in general we were able to set up a model that where we can measure bone remodeling based on HMSC and osteoclasts. We will now test in the next step different hydrojet processed surface topographies with distinct micro and macro structures. Abrasive particles that are in contact with bone-forming HMSCs or precursor cells of osteoblasts have low effect on these cells. However, the osteoclast precursors in themselves definitely are interested in these particles, and their differentiation is impaired by the presence of these particles. Here, our next goal is to determine, okay, what concentration can we allow to be present on a surface in order to still allow for normal differentiation. With that, I want to close my talk. Thank you for your attention, and that is an image of our team, or small team, or 2 people already left us, unfortunately again. But thank you for your attention.
Thank you, Dr. Zuber. Very nice presentation. That is an interesting aspect. Yeah, what's with the particle and the implants, and how is the effect? Dear friends, we can continue with the presentation from Dr. Grunter. Transfemoral amputations as a viable option after uncontrollable infection of knee arthroplasty.
Good morning. Thanks a lot for invitation. I will start with this presentation, which take me to the next researches I've done the last 8 or 9 years. When I worked in a rehab clinic, I see some patients coming up without amputation, transfemoral amputation, after uncontrollable infection of total knee replacement. Aim of this first study was how much people we will have to amputate because uncontrolled PGI of TKR. Because infection, we all know this is one of the most feared complications we have in orthopaedics. Worldwide, we found infection of TKR from 1 to 4%. In the German register, we find 3%. And the second revision, we find infection from 23 to 30%. It's a very, very high cost. I will take this patient. He comes to a clinic with the first implantation of total knee replacement. 2 weeks after, she has an infection with MRSA, Pseudomonas, and Streptococcus. Revision by surgical procedure, 66 years. After that, 1 year later, swelling and pain of the right knee. Prosthetic infection, 68 years with Staphylococcus aureus multi-resistant. Removal of the cemented TKA. After that, what's called a space with vancomycin, because it's biofilm active. 3 months later, implantation of a second cemented total knee replacement. After that, scintigraphic sign shows once more loosening, once more removal of a second TKA. And so on spacer, then we found Pseudomonas aeruginosa, A. morganelli, and deep vein thrombosis. We put an intramedullary rod inside, and we found after that 1 month later loosening of the intramedullary rod. After that, we've done a transfemoral amputation, and we saw it's the first time the next infection with multi-resistant Staphylococcus aureus. We make a second stump revision, and after that we found once more MRSA. We do a second stump revision, and we found here in the rehabilitation. Conclusion. This lady have 13 surgeries after primary TKA, consisting of 10 surgeries of salvage procedures, saving the limb in 2 years. 1 surgery, transfemoral amputation, and 2 surgeon revision of the tide of infection by MSR of amputation. In total, it was 25 surgeries. In this years, she had 431 days of internation and 33 months of illness. I have had a lot of work because for data protection is forbidden for the insurance to get the whole times for internation of the patients. And I have a good friend from the AOK. I will do it in PDF for you, Dr. Teslav. I have a good friend in the AOK, and we've called with the institution with the prices, and I phoned to all these hospitals. The first universities, they only got of the DRG only per day 273 euro. When they've done the amputation, it's the 5th, they get in 1 day 524 euro. Then in the year rehab, you have only 131 days. This was very heavy. It needs more than 1 year to talk to the AOK with a lot of directors. It is forbidden, and we got it. Then we saw in 2008 3 hospitalization of MRSA. 2009 3 hospitalization Pseudomonas morganelli. In 2010 4 hospitalizations MRSA, and we saw all over 185,000 euro only for 1 patient for 3 TKR. Summary. Following primary cemented TKR in patient underwent certain major surgical procedures over a period of 5.5 years because of persistent MRSA infection. 10 salvage limb salvage procedures, 1 transfemoral amputation, 2 stump revisions. Overall, it cost 185,000 euro in 5.5 years. Limitation, only 1 case. The cost in 2012 was only 185. I had a look to the financial. Today will be more than 252,000. Thanks a lot for inviting Dr. Teslav.
Dear Archie, you have, thank you very much. The financial aspect is very important. It's in Germany too, in other countries too, especially in the poor countries. Yeah. Archie, you have a second presentation. If you want, you can take it now. Okay? It's okay for you,
yes,
this change?
Thanks, very good. This presentation take a lot of, where's the mouse here? Yeah. This was only randomly case I found because I've had in the rehab, we have 4 or 5 patients with infected TKR. Yeah, that is. Therefore, I made a study. I presented it as the EBGIS. In the EBGIS and in the Endoprosthetic Congress in Berlin. All years we have it in February. And when I presented in 2014 in the EPR Congress at Berlin, he told me, you have to do more about this. And then I was studying, and I have a good connection to the Endoprosthetic Register in Berlin, and I studied registers all over the world. There I will tell you now the numbers over the world, and therefore Dr. Tetzlaff, that's why we can invite you to take this presentation for you. It's very interesting. There we saw that the infection isn't only a case of one in our land. I don't have any disclosures. In my when I was in the rehab clinic, I have all amputated patients come in with a statistic. I've had 787 amputees, 437 patients with transfemoral amputation. 10 patients of this, 2.3%, I think it's a lot, had an uncontrollable infection of TKA. The Bartle index, that's an index for the mobilization of the patient before internation and after, it's coming up from 60 to 76. And the mobility class is a classification of the patient when they come to the rehabilitation, which mobility they have, and after they go out of. We found the most patients are able to do their relative work in the activity of daily life. Then I spoke to the Endoprosthetic Register of Germany. We found in 2020 3.1% of revision rate. In 2021, 3%, 22 we found 3%. They changed now the failure rate from 3 years to 5 years. Therefore, we don't have numbers in 23. In 24, the failure rate in 5 years, 5.6%. The global burden disease in 2020 showed that Staphylococcus aureus is the most common germ. In our study, we found 30% MRSA, 10% MRA, and mix. This, then I studied the registers. It was a lot of research. I found 37 registries. The most are in Europe. We found that the number of the revision rate is between 14 sometimes to 30%. In infection of this revision rate, we saw in Austria 34%, in Belgium 22%, in Denmark 18%, in England it's 23%, and so on, Finland 28%, and Germany 15%. Then we see some other registries. They started register, but they don't get numbers. In Ireland, they have an infection rate of 46%. In Netherlands, they have an infection of 24%. In Norway, and so on. And I will show the difference. Then I've studied Europe, Romania. You see this here. 18%, Slovakia 20%, Spain 20%, Sweden 40%, and it's very interesting because the statistics of Sweden is very hard. It's very strictly, and they show 40% of revision rate of all TKR from 2%. Then I have the international literature. Australia, we have a revision rate of 3%. Infection of 27%. In Brazil, where I'm living now, we are doing the registry nearly 3 years. We don't have numbers about it. Canada, we find 34%, New Zealand 33%, Pakistan 18%, and so on. Discussion. Studying this national international literature shows changing TKR failure modes are limited when derived from single institutions or regions may not accurately reflect it. Broader international patterns. Multinational registry studies have demonstrated substantial country-level variation and a growing contribution to infection-related revisions. Difficulties and limitations. A view of these 37 registers reveals a highly heterogeneous topic. Some data only available from published articles, Austria, Poland, Portugal. During the comprehensive review of this register, it was necessary to accept the lowest common denominator in order to ensure comparability. In years of data collection rate from 1 year, Austria to 40 years, Sweden. It is difficult to determine orthopedic society, NHS, or government. Sometimes only curves, I have to pick the numbers that don't have numbers. Some registries do not differentiate between total knee replacement and unicondylar knee replacement, Belgium, Denmark. Not all registries report infections. For aseptic loosening, it is nearly impossible to obtain a total number. For example, revision rates are very different. For the first 90 days in Netherlands are not a revision. Exchange the insert, now a revision. Conclusion, and we have a lot of discussion in the German registry, and we explorate a total number of 200 patients per year who lose their leg caused by an uncontrollable PGI of total knee replacement. This is very hard. Since October 23, the endoprothetic register and the section of musculoskeletal infection of the DGO introduce additional questionnaire tool that, among other aspects, inquires about pathogens. That was a long disc, more than 10 years, to put this inside the register. I thank you for your attention.
Thank you very much.
I will do this presentation for you to in your congress.
Okay, thank you. Actually, how did you find the data? Yeah, it's very interesting. Yeah, 4 to 6. I think excuse me. We can discuss now this problem now. This is very important. The number of the infection revisions is very high, higher than our imagination. But the real word was from Professor Alizadeh. He says the number of aseptic loosening, yeah, is one thing. In the 20% of this necrotic loosening, you find bacteria. And together with the primary revision, because infection, you have, that is correct, but very interesting. Thank you very much. Okay, thank you.
It was a very hard research about this. It's neat. When I do it all the years, it nearly 4 weeks to do this. And when you have to Sweden register, it's very good. You have to pay. And I knew the Swiss one because of friends of mine. I don't have to pay. They have to pay 250, 300 euro.
Yes, it shows how important the register is. It's very nice. Thank you very much. Yeah, Achi. Yeah, thank you. Okay. And the next and last 2 presentations belong Dr. Ghazal, and thank you for the next. You can have both.
Thank you, Dr. Tizwell.
No?
Yeah, okay.
This?
Wait, yes.
Okay.
The next I will talk. Okay, we'll finish this and we'll talk about the next. Okay, we'll finish this first.
Moment.
This is okay.
Next.
Yes. Okay.
Here?
Okay, this and this. Okay.
Die letzte macht ihr.
Hello. I promise this is the last talk. The last two talk. The first of my professor, Dr. Fadel, and you know the reason. And the next is mine. In this quick talk, I will talk about orthoplastic technique in bone defect reconstruction. As you know, the last 2 days we talk about defect, how to reconstruct bone defect, many methods. And in this talk, we will talk about a different technique, but out of the box. Okay. Our case, for the example, case or presentation, the case of infected or open fracture with fixator, comminuted tibia, with uniplanar fixator. We don't like uniplanar fixator, by the way. Signs of liquid infection, severe pain tract infection, unstable XFX, outboring pus, loose pain, X-ray show necrotic bone and comminution. Plan. Conventional technical steps. Careful soft tissue handling, indirect reconstructive techniques, minimal invasive surgery, tension-free closure. Our rule: enlarge infected bone mass. Remove XFix, it loose by the way. Debridement, systemic antibiotic, local antibiotics. Then re-debridement again, and the tibia left 15 centimeter defect. Unlucky patient. After 4 weeks follow-up. Large effect, how to reconstruct. The specific method of skeletal reconstruction of massive bone and soft tissue loss remains a topic of controversy. The problem increased in case of bone and soft tissue defect due to massive bone loss, extensive soft tissue scar, vascular compromise, and short tibia remains. How to reconstruct? We know the many different methods of reconstruction: vascular technique, bone transport, vascularized fibular graft. And in this case, we choose vascularized fibular graft, but it's high technicality, and we didn't no more surgeon doing this technique in our country. So we use the Elizarov as a tool in many different techniques. So we thought out of the box. We thought to do vascularized fibular graft without microsurgery, just by olive wires, fibular transfer or fibular transport. We actually transfer. This is the technique. We won't transfer the fibula, and the patient is lucky the fibula is good. Vascular, soft tissue coverage good. Okay. This is the frame. We use the original frame, and this technique, fibula salvage, Elizarov orthoplastic assisted technique, FAIT. Clinical and laboratory is okay. Conventional Elizarov construct, just the construct of Dr. Osman talk about, conventional, but we add it as a plate. طبعا we know the safe zones of insertion of vein. We must know it very well. Conventional Elizarov construct, plate on the top of the conventional Elizarov. There is a plate. You also use this plate on the Elizarov connection plate. Okay. This is a pointer. This is the plate, and this is the olive wire, and I will transfer the whole fibula by the nut here and here to get the fibula from posterolateral to anteromedial to cover the defect with soft tissue and vascularity. This is the shape of the construct. This is the shape of the olive wire, percutaneous. We do a septum proximal. Look to the 3 olive wire from posterolateral to anteromedial and on the plate. Yes, you can also see. This is the photo. Radio. 2 olive wire. Fibula, septum proximal and distal. Osteotomy, many type of osteotomy of the proximal or distal, giggly and osteotomes. Whatever the method you can do it. Then transfer. This is the shape after transferring the fibula. You can all see. After removal, brace for 6 months. Weight bearing, protected weight bearing, not direct weight bearing, don't fracture the fibula. The fibula is weak, still weak. But protected weight bearing, it will enlarge. Challenge. Conclusion, reserve technique provide valuable results in management of fracture-related infection or bone defect reconstruction, eradication of infection, compensation of bone defect, correction of deformity and union. Benefit of nose, no, 9 in Germany. Infection was eradicated, no recurrence, non-invasive soft tissue approach, non-plastic surgery, no vascular surgery, no joint stiffness, no lens discrepancy. Thank you. The next lecture, the last one. No. Okay, thank you. The last talk, I will talk about Charcot neuroarthropathy. I will talk about 10 years of experience with Dr. Fadel in management of diabetic foot. Diabetic foot or Charcot neuroarthropathy, it is very, very rare subspecialty in our countries in Middle East. It is misunderstood by us, and the general and the vascular surgery take the cases, all the cases, and there is iatrogenic ulcers and amputation from our vascular or general surgery colleagues. So Charcot or neuroarthropathy or diabetic foot, it is our subspecialty, orthopedic surgeon, not vascular, who are connecting with us, but you are the leader in diabetic foot, okay? This is LRSPD with Dr. Fadel. Charcot neuroarthropathy is defined as aseptic destruction of the foot, which may lead to massive and complete destruction of bones and joints of the foot and ankle. And this misdiagnosed by general surgery. It is aseptic destruction. When it is diagnosed as cellulitis or septic destruction, it is the first step for amputation. If misdiagnosed from our colleagues, vascular or general surgery, it is cellulitis. So the patient, he weight bear and walking and taking antibiotics and controlling diabetes, but weight bearing is a catastrophic in this stage. It is aseptic destruction. Yes. The progressive denervation induced degeneration of the weight-bearing joint of the foot, typically unilateral localized inflammatory reaction in focal area of the foot, ankle, with erythema, worms, and swelling, often triggered by trauma or repeated microtrauma. Progression, it starts from inflammation to osteoclastic activity to bone instability and collapse. Anatomical classification, hind foot, mid foot, forefoot. Pathological classification, Eichenholz classification, it's very important because you want to know when you will interfere in active stage or in healed stage. Much more different interference. Indication and the timing of surgery. Active stage, significant when I interfere surgically in active stage. Limited roles in active stage. All our surgery in healed stage. But in active stage, for some reasons, in significant joint dislocation. When we see very significant joint dislocation like cuneiform, cuboid, and impending ulcer, you must interfere. Don't wait for the healing stage. Significant instability, unbraceable foot, deformity. Deformity with impending ulcer, deformity with active infection. In inactive stage, unstable deformity, ulcer, unbraceable foot, we can interfere in this stage. All we know is that in the 2 days we talk about miss or mangled. When I ask all my colleagues, when I have a patient, young patient, we will do crush injury, we will do many surgery and end up by painful foot, or a diabetic old patient, many surgery, but to save the limb. When you choose between you amputate this young man or you amputate this old man, what you choose? Young man or old man? Young man, painful? Yes. Yes, I choose amputation of the young man. Very easy. Don't be afraid, but think 100 times to amputate a finger or a two from diabetic foot. As a limb saving here is a life saving, like a neck femur fracture. It's a life saving. Somehow mortality rate for major amputation more than 50%. So we don't reconstruct the shape or weight bearing of the foot. We saving the life of the patient. Okay? Advanced pathology, sharp arthropathy can lead to severe infection with a reported 28 or 37% increase in patient mortality, more than 50% mortality after major amputation. Conservative management in general, first, total contact cast, orthotics. Pre-operative planning, I want to know is it active or healed, inactive, presence of ulcer or not, infection, superficial or deep, massive edema, controlled diabetes or not, radiology and pre-operative radiological planning. Tools of fixation, we have many fixation. We don't use Elizarov or external fixator only. We use beaming, screws, intramedullary screws, plate, internal with external. Okay. Surgical approach, staged or definitive. A staged or definitive is predicated on active or inactive disease, presence of ulcer or not, infection or not. Staged approach in infected cases, we all know that Charcot, clean Charcot, aseptic or septic Charcot. And I can tell you all septic Charcot I met, the cause or the reason is our surgeon colleagues, general surgeon or vascular surgeon. He see active Charcot, it is osteomyelitis, I can cleaning up and he open from the sole of the foot and end up by ulcer and amputation. 70% of amputation could be saved. So 50% of 70% of amputation could you save their life. And there is suicidal attacks in some patients with our colleague or our vascular colleague, and they talk with us about this. There is suicidal attack with young female patients. So staging technique, we do initial irrigation, debridement, culture, and specific antibiotics with external fixator. Then infection subsides, then we do definite fusion. Elizarov, why Elizarov fixator? Versatile. Many patients come with us with poor bone stock, osteoporotic infection. What kind of fixation you use? Infection. External fixator. What kind of fixator? You can use very fine bends like wires. Elizarov. Okay? Rotational and axial instability. Elizarov. Deep infection, with deep infection and deal wound. the pathology, is the pathology with external fixator only, or the fusion with blade or screw, or debridement? The pathology is the neuroarthropathy, nerve degeneration. More than 90% of my cases, I did hundreds of cases around the last 10 years, hundreds of cases of diabetic foot. More than 90% sensation regenerate and recurrence. Especially in the second stage, in the surgery, the patient post-operative feel pain. In the first stage, no post-operative pain. Okay? And when the nerve regeneration become good and the sensation recurrent, the pathology is improved. So the recurrence is decreased. Okay? We don't know what is the reason of the regeneration of nerve. We don't know till now what is the reason of osteotomy or fracture. But I met one case, supracondylar femoral fracture with Charcot foot, no sensation, and I did for her interlocking nail femur. After 3 months, sensation recurrent in the foot. So we don't know, is it about fracture or drilling or interference? Pros, pain tract infection and psychological for most of the patient. Surgical technique, as we told Dr. Tetzval yesterday, you deal with the deformity like any deformity, tibia, femur, you have a foot rocker bottom deformity, you have arches, you have equinus. You must deal with all these deformity to get reconstructed arches or plantigrade stable foot. Or our job not to correct the deformity, but fusion only. And you extend your fusion. If it's midfoot, you extend the fusion to subtalar. Okay? Amputation is a solution. Some patients come to us with very late stage infection, gangrene, and what's the solution? Secondary failed previous surgery, but 10 years experience, no one case failure post-operative, no one amputation, none. Hundreds of cases, zero amputation. Case presentation, first case. This case, she come to me with Charcot hand foot, unstable, walking with the lateral malleus. She has amputation of the big toe from general surgery before 1 year for she to come, and she entered in Charcot ankle. This is the shape of the X-ray. Talus resorbed, midfoot dislocation. So this is the shape of the talus. It is aseptic neuroarthropathy, not septic. I use the talus as a graft. I didn't use a graft iliac or fibula. The talus is a good graft as shape. And I use 6.5 cannulated screw with the Lazarov late after many cases for securing the fusion later on. And this is fusion. Fusion, the most difficult fusion you met, tibio-calcanean fusion. Very difficult. The tibia like this, the calcaneus like this. Bone contact, very difficult. So I use big in-hole technique, convex, concave. Yes, convex, tibia, concave, calcaneus. And this is the shape after removal of the Lazarov. The fusion is very good, very strong. And this is the female after removal of Lazarov 2 months. This is the video. Walking, plantigrade, stable, without assistance, very short time after removal of the Lazarov. Case number 2, male patient, 42 years, old, presented with Charcot midfoot, active stage with plantar midfoot ulcer with active infection, osteomyelitis, exposed bone, debridement. He told to amputate his limb from all surgeons. And who did this ulcer? General surgeon. It is charcot active stage. It is osteomyelitis. I can open and debride. He didn't debride. He take all the bone of the midfoot. What's the solution? Amputation. I didn't give him a hope like all our cases, but I can try. You will wait? Okay, I will wait. Clinical photo, radiological. This is the photo. All what I did, debridement, stabilization. When you want soft tissue healing or infection to subside, you must stabilize even soft tissue. Midfoot, no bone, very mobile. Even in dressing debridement, soft tissue healing never become good. Simple frame, as you see, one ring above, two half ring. Okay, this is the photo after 1 month. Just dressing, nothing, no vacuum. Just dressing. Stabilization is the key. Shape, and after 3 months. And you have a video. After 3 months only, he full weight bearing, without ulcer, without infection, 42 years, policeman. If I amputate him, mortality rate more than 50%. Life saving or limb saving. Case 3, charcot ankle. It is closed charcot ankle, open, turn it to septic charcot. As we see, infected charcot ankle. We decide to do staged technique, debridement, cement spacer, Lazarov fixator, then removal of the cement and diffusion, big and hole technique. And as you see, I removed the Lazarov vat. I didn't put the photo. Okay, plant great foot, fused ankle, stable, saved limb. Case number 4, 38 years old, present infected charcot by general surgeon. It is closed charcot, open, turn it to infected charcot, and they told amputation. All these patients told to be amputated. 38 patient, young male, infection, staged approach. As you see, we removed all dead bone and cement spacer with simple frame, fusion, 6.5 cannulated screw. I added in the late cases. Female patient, 42 years, midfoot charcot, plantar ulcer. She told to be amputated, and there is a hope. This is shape of frame. This is the arch of the foot, internal with external, not Lazarov only. And many cases, internal only, but this lecture about, this talk about Lazarov technique only. This is the shape of the foot after 2 months or 3 months, I don't know, don't remember. Complete healing of the ulcer. I remove the Lazarov and leave the beams for the lead. Take home message. Lazarov option is suitable for most cases of diabetic foot reconstruction. Lazarov circumfixator used in infected cases, active stage, poor bone stock. Mortality rate is high after major amputation. Salvage is the rule in our cases. Pathology, sensation, and vascularity could be improved in most of limbs reconstructed. Need more documentation. And I will thank first my professor or my mentor, Prof. Dr. Fadel. I started all my subspecialty limb reconstruction surgery in infant, adult, infection, even in diabetic foot. He is the key. He is the first step in Egypt. He learned us diabetic foot and learned many of the young surgeons in Egypt and Africa and all over the world. From here, I thank my professor, Dr. Fadel, for all what he did for me and my colleague. Thank you, and thank you, Dr. Titzwell, Dr. Mahmoud Alwan. Thank you. Thank you for hospitality. Thank you.
Thank you very much, Dr. Ghazal, for the fantastic cases, impressive cases. Yeah, that was, ladies and gentlemen, the last presentation of our Congress. I think I have to greatly thank our friends, you, for the coming, for the lectures, for the protection of Congress. And I think we had many interesting and impressive lectures and presentations from around the world. And I thank my colleague, Dr. Olvan, and Professor Osman, and the other Egypt brothers for this presentation of Elizarov. I think an applause for the people especially, please, yes? Well, I am very sad in fact that we don't have the Mr. Fadel, Professor Fadel here. This is very difficult for visa. That was a very negative surprise for us. But the competent colleagues make it. Thank you very much for our attendees. Thank you very much for the colleagues. Thank you very much for the patients that was here. Thank you very much for the colleagues from Klinikum Dortmund. Thank you very much for all people that has protected us in our Congress. Especially thank for all of the management, Mr. Fabek, Mr. René for the equipment, and Marcus, applause, please, for you. Yeah. Fantastic live meeting from Gaza, fantastic picture and tone quality. Thank you very much, René, Marcus, Frank. Thank you very much. For the catering, for all the people, with the protection of the sponsors and industry, and I think in the momentan hard situation of the world, here is some safe piece of the world. And I think when we go out, we can say one of the most important prevention for osteomyelitis is to avoid the wars. Okay, thank you very much for coming. Have a nice day, have a trip, have a fly. I hope we can see you as soon as possible, for example, in Buenos Aires. Thank you very much, my friend. Thank you very much. Yeah. Just a moment, please. Before you leave the area, you have the possibility to have a lunch pack to eat. Please take it, and please don't forget your certificates, yeah, at the door. Yes, thank you.